I'm Gregg Pressman. I'm the Associate Program Director for the Cardiology Fellowship at Einstein Medical Center in Philadelphia. I'm here at the International Academy of Cardiology 2017 Scientific Sessions. I've just presented on the clinical importance of cardiac calcifications. I think we're all well familiar with calcifications as encountered on routine echocardiography. However, I think we often don't pay much attention to them. There is, however, a developing literature to suggest that they are clinically quite important, and in fact, interest in calcification in general has increased greatly with the advent of TAVI, or TAVR, depending on where in the world you live. Calcifications tend to be found in the aortic valve, the aortic root, the mitral annulus and valve, and the submitral apparatus, particularly the papillary muscles. We know from multiple studies that they are associated with the presence of coronary calcifications, and of course, coronary calcifications are a marker of coronary atherosclerosis. Calcification can also involve the conduction system and lead to varying degrees of heart block. It is strongly associated with the presence of chronic kidney disease, and it is associated with all manner of cardiovascular events, including stroke and mortality. Last year, we published a study in the Journal of the American Society of Echocardiography where we used a semi-quantitative echocardiographic score accounting for all calcium seen on the echocardiogram. It assigns points based on the presence of calcifications in the aortic valve leaflets, whether or not those leaflets are restricted in mobility, whether there's calcium present in the aortic root, the mitral annulus, the mitral valve, the subvalvular apparatus, and whether the anterior and or posterior mitral leaflets are restricted. This score can range from 0 to 13. It is, again, semi-quantitative, but it accounts for all calcifications seen on the echocardiogram. This score was then tested in a set of 443 patients who underwent clinically indicated echocardiography. They were otherwise unselected, and we saw a near linear relationship between the score and subsequent mortality. Even after we adjusted for multiple clinical factors and other echocardiographic parameters, the relationship with mortality was significant. Similarly, the relationship with stroke was significant and remained so after multivariate adjustment. So in conclusion, we should pay attention to calcifications as they provide an important clue in your patient to the presence of coronary disease, conduction disease, chronic kidney disease, and risk for cardiovascular events, including stroke and mortality.